and welcome to this Ozarks Technical Community College Town Hall about COVID-19 for OTC employees, and thanks a lot for joining us today. I'm Mark Miller, the college spokesperson, and joining us today is Dr. Robin Trotman, an infectious disease expert from Cox Health, and of course our Chancellor, Dr. Hal Higdon. So first, a little background on Dr. Trotman. He attended the University of Texas at Austin for his bachelor's degree. So his Longhorns will soon join the Southeastern Conference along with Dr. Higdon's Alabama Crimson Tide. I got Dr. Higdon to promise that there would be no football trash talking today on the webinar. So Dr. Trotman, rest assured that's not going to happen. He also went to the Kirksville School of Osteopathic Medicine with internships and residencies at Mizzou. Plus, he did a fellowship in infectious disease at Wake Forest University in North Carolina. He's also an assistant professor of medicine for the University of Missouri. And most importantly, he's a fellow in the Infectious Disease Society of America. So most important to our discussion today. So Dr. Trotman, thank you so much for taking the time to join us today. I'm going to jump right in with questions that were pre-submitted from our employees. So Dr. Trotman, just first of all, is the vaccine safe to take?
So, I speak to this, and there are about 100 aspects of the safety of these vaccines that people want to hear about. And, we haven't prepared for these. This is going to be casual dialogue, I hope, because people don't want cable news talking heads condescending to them, and they just want to know honest neighbor opinions. I live in this community. I have family here, kids here. Here's the thing that speaks to people the most. I have 12 and 14-year-old daughters who both got the vaccine 5 days after approved for kids. Okay. So that is probably the glaring feature around the safety about the two things I care the most about in my life. So my interpretation of all of the evidence about safety resonates so strongly that I would give it to my two most dear treasures in my life. We're going to talk about this outside of the context of the misinformation, right? So if we have vaccinated 180 million people, what have we seen? What have we seen as signals of any type of concern with the vaccine? People's arm hurts, they get lymph nodes, they have a fever, they feel crummy. I couldn't hardly get out of bed that night after the second dose. So those are good things. At Cox, we vaccinated over 110,000 people, and nobody has died as a result of the vaccine. So misinformation number one, 12,000 people have died after they've received the vaccine. Well, let's think about numbers and just normal actuarial data. If 180 million people have been fully vaccinated, and there's over 300 million vaccine doses out there, the normal death rate in the human population from car wrecks and cancer and heart attacks is such that there is not a spike in death rates after this vaccine. So it is true that people have died after receiving the vaccine. The vaccine, as Paul Offit would say, and we'll talk about that later, it doesn't give you invincibility. It doesn't make you not vulnerable to car wrecks. So there is, when people say that, what about the 12,000 people who died who have the vaccine? If you put that in the context of 300 million doses of vaccine, it's what we would expect. I'm going to just talk about a couple of the things that do happen. So there are some signals of some very rare side effects with the vaccine. It's safe enough that all of these side effects that I'm going to talk about, potential rare side effects, outnumber the rate of the similar conditions from the natural disease. Oftentimes, a vaccine side effect is similar to the disease, just much more rare. So we see Guillain-Barré after influenza, and 1 in a million people with the flu vaccine can have Guillain-Barré. So these associations exist, but they're far less common after the vaccine. The first one that people hear about is myocarditis, inflammation of the heart. So what we know is maybe 1 in 50,000 young men, adolescent men, can have inflammation of the heart. Then you compare that to the rate of myocarditis after COVID. Now, all of these cases of inflammation of the heart, 1 in 50, 1 in 70,000 cases, have all been reversible, not fatal, and self-limited. But if you get COVID, you have about a 1 in 50 chance of inflammation in the heart as seen on cardiac MRI. So 1 in 50,000 versus 1 in 50. So they looked at Big Ten athletes, and they published this in JAMA. So Big Ten college athletes, they had COVID, they did cardiac MRIs on them. And it's about a 2.3% of those people had inflammation in their heart, because they don't want these athletes to return to participation and have sudden cardiac death. So they scanned their hearts, and they found about 1 in 45, 1 in 47 had inflammation in their heart. So you got about 1 in 50 had myocarditis, not always symptomatic, but could be if they participated in, run track or whatever. And then 1 in 50,000 after the vaccine. So that's the kind of risk that we're talking about. No decision in life comes without risk. This is not a risk-free decision to take this vaccine. It's, do you want the risk that that's rare, 1 in 50,000 myocarditis, and this, or do you want the unknown risk of what's going to happen with the infection? So that's how I help people understand these safety issues. It's not a risk-free decision like everything in life. But do you want the known risk, which is rare, self-limited, or do you want the unknown risk of the disease? So when I tell people, I want to be honest, and I want to say there are rare side effects. Guillain-Barré, 1 in a million after the vaccine. So some of these issues I think should help people understand and hopefully give us credibility. I wrote statistics down in case I get specific questions, but none of the side effects from the vaccine are even remotely on the order of 1,000 times as common as the complications of having COVID-19. I hope that makes sense.
That makes perfect sense. Essentially, what you're saying is that the risks of getting COVID-19, the health risks, far outweigh the minimal risks of taking the vaccine. One specific question we got 2 or 3 times was about fertility, reproductive health for young women. What can you tell us about that?
Yeah, that's a good one, because that's the unknown, right? That's an emotional trigger for so many of us, and I completely understand why people are hesitant to that, because it's something that's hard to prove. If you get a vaccine and you have arm pain or it turns red, that side effect. But if you have issues and questions around fertility, how are you going to really know? But let's just back up and go, where do these concerns come from? And if you really want to go down the disinformation rabbit hole, this is one of the most illustrative issues around public disinformation. And it literally has resulted in loss of life. So the disinformation and the fear around infertility and the vaccine has resulted in people not taking the vaccine and becoming sick and oftentimes dying. Now, the wave we're seeing right now is very different than a year ago. A year ago, we had lots of older patients from nursing homes. We have parents of school-age kids. We have people that I look at that are my contemporaries. So this issue around protecting that population is probably even more important now than it was a year ago. But if you look at if you want to know, do these mRNA vaccines affect fertility? We don't have any signals of that yet. If we vaccinated almost half of the US population, we should see birth rates going down, right? And we're not seeing that. If you look at the phase 3 studies where they gave it to placebo and Pfizer vaccine, placebo and Moderna, you had the same amount of pregnancies in the placebo group that you did in the control group and the mRNA vaccine group. So as of now, if you look at the big data, there are no signals of infertility around this vaccine. American College of Obstetrics Gynecology, they recommend it. These are the people who are out to protect women of childbearing age. I mean, these are the biggest advocates for those people. And they're the ones who sift through the data, and they don't want anything to affect their population, and they advocate for the safety of the vaccine. So I think this notion of the spike protein and the syncytial 1 protein, that's misinformation. That's not even remotely scientifically proven. People want to know, well, if you make antibodies to spike protein, it cross-reacts with placenta proteins, but people make antibodies to spike protein when they get naturally infected, but then they can still get pregnant. So we have people who were infected last year and they still got pregnant. So those antibodies to the spike protein from the virus and from natural infection versus the vaccine, they're the same antibodies, yet people are getting pregnant. So as of right now, we don't have any signals of fertility issues, and the data would suggest that it's safe for those. I hope that clarifies that. it's a tricky one that early on we had just a rush of disinformation from people who were disenfranchised Pfizer employees that had a track record of conspiracy theories. And so we can see where this was born out of, but we just follow the data. We follow the evidence. We look at, are we seeing a decrease in birth rate? What did the phase 3 studies show? And that's where the evidence is.
Gotcha. Dr. Trotman, thank you. I'm going to switch to Dr. Higdon here for a few minutes. And Dr. Higdon, we answered many of the questions we got in yesterday when we announced that masks will be required for everyone starting yesterday. Take us through the thought process that got the college to that point and why we decided to require everyone to wear masks and not just the unvaccinated.
As the community college, we can't ignore the data that we see. We see the illness, we see the hospitalization, we see the death rate. Our colleagues at Missouri State and Drury saw the same thing. Springfield Public Schools, Bolivar Schools were public schools. And I did not want to be at this place. I did not believe we would be at this place in May when we ended this, but we did not account on the low vaccination rate. We didn't count on the Delta variant. So we took all that into account. If we were at 90% vaccination rate in this community, we wouldn't be in masking probably. But until the disease lessens and the vaccination rate goes up, we're going to have to be masked.
And Dr. Higdon, we're not going to require vaccinations. Take us through that process right now.
Right. We're not requiring vaccinations. The only people that will have vaccination issues are those allied health science students, where the hospitals where they do clinicals require those vaccinations. And obviously that's beyond our control, and we certainly support that decision. But the college will not be requiring vaccination by employees or students.
Dr. Higdon, one thing I got was, well, we require other vaccines. Why wouldn't we require this one? We don't require vaccines as a college. Mainly
right. We're not a residential facility. When I went off to school, I had to prove my vaccinations because I lived in a dorm. If you go to Mizzou and Missouri State, you do. We don't have dormitories, so that's not an issue for us.
All right, Dr. Higdon, thank you. Dr. Trotman, I'm coming back to you here for a few questions. There was a very specific question about the VAERS website, or the Vaccine Adverse Event Reporting System. Questioner says that their family members are telling her that thousands of people are dying, and you've addressed that. But after taking the vaccine, talk to us about that VAERS reporting website and causality versus correlation.
Yeah, I mean, that's a volunteer. So here, okay, let me back up. Anytime you have a drug, you have what's called pharmacovigilance, which means we're going to be vigilant about monitoring for unforeseen complications. And vaccines have always had this adverse event reporting system, which is voluntary, and they get screened. Now we also have the app. If everybody's had the vaccine, you have the app and you can punch in how you're feeling at that day. And then we have ongoing clinical trials. So there has never been a drug in human history with this degree of what's called pharmacovigilance. So follow-up and safety monitoring. When you start talking about 300 million doses out there and you talk about vaccinating the world, and we're looking at these with vigilance that it's never been done before with any drug. We all take medicines that have not had this much experience, both in clinical trials and in pharmacovigilance. So this is being followed with incredible scrutiny. Then what you do is you look at the fact that, like I said, people are going to die after they receive the vaccine. I mean, I don't think that anybody ever suggested that the vaccine is going to provide immortality to people. It just doesn't. And so the VAERS reporting system reports numbers, out comes the death rate, and that doesn't make a causal link at all. And so, people are going to have cancer, they're going to have car wrecks, and there's going to be traumas immediately following the vaccine. When you start talking about numbers of 300 million doses, you're going to look for things like disproportionate death rates in the vaccinated group versus the general population. And we have those statistics, the deaths get reported. And so we know percentage of car wreck deaths, and we know percentage of, so that's where those numbers come out. It doesn't tell you that this vaccine caused that. We're not seeing an increased death rate in the population short of COVID-19. So what we do know is we know that at one point in time, we were having 2,000 deaths a day from those severe infections. That is going to affect the national death rate. But we're not seeing that from the vaccine. So to your point, causality versus that a death is linked, it's pretty clear. And then we look at our healthcare system. I mean, how many have we vaccinated through Cox Health? Over 100,000, and we're not having people die from unexplained causes. We haven't seen that at all. So that's a hard one to put down. People just hear that, and that one's easy to beget on social media platforms. But yeah, there's not a causal link.
So then the big question is, okay, so you're telling us it's very safe. Then why doesn't it have full FDA approval and only the emergency use authorization? Can you talk to us about the difference there and kind of that extra scrutiny it has to get beyond the EUA?
So the emergency use authorization, so first of all, this vaccine went through the same clinical trials that any other product goes through the FDA, phase 1, phase 2, phase 3. Here's the difference. When the government through Operation Warp Speed said, we're going to underwrite this process, we're going to pre-purchase vaccines so that the manufacturers don't have the risk. So the manufacturers can build the manufacturing facilities, hire the people, buy the vaccine making stuff in advance of seeing it go through phase 1 and phase 2 and phase 3. So the infrastructure was already there. When a phase 1 study is done, they send it to the FDA, they look at it, they wait on a hearing, it may be 6 months, then they go to phase 3. The FDA said, this is important. We're in the middle of a once in a lifetime existential crisis. We need to expedite our normal bureaucratic train that goes so slow. So they put these studies actually in tandem. So phase 1, phase 2, phase 3 can run without having to wait on a period where you're waiting on the FDA and some sort of hearing. So that really squeezed the time down. That's the same process you would go through full licensure through the FDA. When a drug or device or vaccine gets full approval from the FDA, everything gets authorized. The manufacturing process gets scrutinized. It's a completely different process than saying the vaccine is safe, because what's going to happen is other manufacturers are going to come in and use that same technology and that same blueprint. And so they have to approve the whole process, you understand? And they have to be able to say, here's how you keep your factory clean, here's how you have quality assurance, so that someone else could come in and do that behind. That's what full FDA approval looks at. And you do want to have safety data several months out, and we didn't have that urgency. I mean, we've been given this vaccine for over a year. So we have far more safety data than many fully licensed drugs that are out there right now. I mean, way more. And we've been giving the phase 2 studies were way before August of last year. So we have tons of data. The FDA probably around September will put the rubber stamp on it. But again, they have to look at the factories, make sure everything's standardized, all of the process of manufacturing, quality assurance, maybe mid-September. That's what they have to assure to get full approval, so that anybody could come in behind them and duplicate that and make with consistency the same vaccine or drug. So yeah, I mean, it's a global health crisis. We don't have the time to ensure that it's standardized so that anybody can pick that up. And that's the difference in the EUA.
So maybe just what I heard you say is the medical portion of it, the testing portion of it, to make sure that there are no side effects and things like that, that all has happened. Really, it's more the bureaucratic, the checking of the facilities and all that stuff. That's still what is awaiting full FDA approval. But the portion, the safety portion, the safety for human beings, that's done, and they're sure of that.
Yes. So those phase 3 studies, let me explain something. This is, if anybody is a science person, you're going to really get a kick out of this. When you do science, you have to wait on enough of the disease. If you have a disease, you're trying to prevent it, you have to be able to show separation with the vaccine group and the placebo group. When there's so many cases in the community where you're given the vaccines, they showed that separation really quick. I mean, the vaccine studies, they gave it to 30,000 people. They thought it was going to take months and months, but there was so much COVID infection that the vaccine group separated from the placebo group, and it would have been unethical to continue to give people placebo at that point, because they knew they were saving lives. that is the hallmark of a very powerful study when you can't even, when it finishes, you have enough patients enrolled to show statistical significance, so significant that it would be unethical to continue to give placebo to people. And so that's how the vaccines made it to fruition so fast, because there was so much disease. If it was a rare infection, if it was tetanus, I mean, we would still be studying it because we don't have enough tetanus cases to show benefit with a vaccine. So yeah, all of the study outcomes, all of that, that's the same as the medicine that you're taking for your thyroid or your blood pressure or your diabetes, identical process with even more pharmacovigilance. So, but yeah, it does make people nervous because you go, how did they do a phase 3 study so fast? Well, because the burden of the disease was so high that they were able to show a difference between placebo and drug quick.
I got you. Well, then I think a lot of people's concerns then, a lot of the questions we had, how can we know the long-term side effects, or potential long-term side effects of the vaccine if it was in this compressed time period?
I mean, so at that point in time, I would argue, how do you know the long-term side effects of getting COVID-19, right? I mean, you don't know the long-term side effects of the apple that you just ate, right? We know that this mRNA that we inject in your muscle is gone pretty quick. Your body has mRNA in it all the time. It chews it up. You have digestive enzymes in your cells to degrade it. That mRNA is gone. The lipid nanoparticle is out of your system. So, we haven't ever had a vaccine that had a 1-year post surprising side effect ever in the history of vaccines. There's never been a vaccine where 2 years later we went, oh, oops. All of these things, once you give them to 5 or 6 million people, you see the side effect. That vaccine is gone. So there's no precedent for somebody to say, well, what about in 10 years? Well, I mean, what about the energy drink that you just ate? You have no idea what's in that. At least I can tell you what's in this, and I can tell you the disposition of all of the compounds that are in the vaccine, and they're gone. So I feel safer with the disposition of that vaccine in my body and what's going to happen than I do the long-term side effects of COVID. I have a whole clinic full of people that, still can't walk up a flight of stairs. Their brain's still foggy, can't smell. They missed work. They lost their job because they were out sick and couldn't perform their function. So, I mean, for people going through OTC, if you're about to come out and hit the workplace, you want to be bomb-proof, right? You don't want to go get a new job tomorrow and be out for 3 weeks with COVID. That's not going to look good with your employer. So this really is the way out, especially for young people going through, training and trying to find employment.
Talk to us a little bit about people were vaccinated but still got COVID, or they're vaccinated and we're hearing that people can you still spread COVID? Those are, what does it mean that, I got vaccinated, I still got the disease, or I may be asymptomatic and we're hearing that you can spread the disease. Can you talk about those issues?
So it's a respiratory virus, right? So there's a 5-day incubation period. Somebody coughs in your face and you have virus in your nose and your throat. That your immune system is in your blood and your lymph nodes, some in your throat, but it takes a few days for that to rev up and do its thing. So you're vaccinated, you may get a runny nose because the virus is replicating in your nose. We know that we can find viral RNA in your nose, but we don't find a lot of viable virus. And those people don't go on and get sick. So never before was this virus advertised as preventing infection. Okay, infection means somebody coughs in your face, that virus is coming in your nose. Like, it's not a barrier, a mask is a barrier, a face shield's a barrier. And it's gonna replicate in your body and it's gonna be detectable with a swab, but you're not gonna get critically ill. Now with the Delta variants, we're seeing rare cases in people with weak immune systems who do end up in the hospital, but it's very, very rare. So yeah, you can still get infected if you don't take care of yourself. That's why you guys are gonna have masks even for vaccinated people, because I can't guarantee that I don't cough something in your face, I don't talk, put respiratory droplets in your face, and then you transmit to somebody unvaccinated. And so we have to stop that chain. Every time this virus replicates in a different person, it mutates, and it's going to mutate and escape our vaccines and our own immunity. And 3 years from now, if we don't get a hold of this, we're going to be back where we started. So yes, there are chances you could get infected. You will not likely get sick and end up in the hospital. Your duration with which you can transmit the virus is going to be shortened incredibly. Your illness duration statistically is going to be shortened, and you're going to transmit way less. So when they, the study that you just looked at from Massachusetts, that's kind of what changed the masking with the CDC. I mean, that was based on them being able to detect RNA in people's nose, which is exactly what you would expect if you were unmasked, somebody coughs in your face. So the distinction is it is intended to prevent severe disease.
Okay, Dr. Trotman, I'm going to switch back to Dr. Higdon. Are you okay to go a little past 4:30?
Yep.
Because I got 4:27. I'll try to be quick here. But Dr. Higdon, people want to know, what are our quarantine rules for those who are vaccinated and exposed or unvaccinated and exposed?
They're different than last year because we didn't have vaccination. But if you're vaccinated and exposed to someone who has COVID, but you do not show symptoms, you do not need to quarantine. If you are unvaccinated and exposed, whether you are symptomatic or not, you must quarantine. If you're symptomatic, regardless of vaccination status, you must quarantine for 10 days.
All right, and we're gonna fire up the contact tracing, case management. I mean, that's been going all summer. We haven't had as many students on campus, but that's going to be going, right?
You're right. So if you're an employee or a student and you test positive, or that whole protocol, you will contact just like you did in the spring. And hopefully everybody will be vaccinated and masked by the time school starts, and we'll have very low incidence, but knock on wood.
And testing this semester, Dr. Higdon, we're not going to have on-campus testing.
We did on-campus testing when testing was rare, hard to find. You can now go to the health department, you can go to the hospitals, you can go to Walgreens, you can go to CVS. So, and you can go get testing. So we won't be doing testing on campus.
And then, you talked about quarantining. So if you're exposed or if you're symptomatic, what's in place for employees who may have to quarantine for themselves or for a sick child?
We have a very generous sick leave and vacation pay and vacation leave and personal leave. And if you're out sick, you would use your leave just like normal.
And I think, Dr. Higdon, it feels like 100 years ago, but it was just, March of 2020. We shut the college down and moved everything online, and then slowly brought back those lab classes. I think everybody's wondering, what are the chances we could get back to that?
Barring a massive outbreak of disease, and that would be something we'd do in consultation with the health department, people like Dr. Trotman, Mercy, and Cox. I don't see that happening. We learned a lot of important lessons. By the end of that semester, we had figured out in tech ed and in health sciences how to do socially distance labs, that sort of thing. But the big thing we learned is that masking works. Dr. Trotman told us early on it worked. We listened, and I don't think we're going to have any problem making those work here in the fall, or hopefully this will be lessened by the spring or even the spring. My hope is that we end masking as quickly as possible, but that's up to the disease. And frankly, it's up to our employees and our students to get vaccinated if they're not already.
And our community overall, right? So
yeah, if only OTC gets vaccinated, it doesn't do any good.
That's right. Yeah, we could be 100%
Southwest Missouri.
We still have to live in the world, right?
Right.
So Dr. Trotman, Dr. Higdon talked about masks. Talk about those. Do they help slow the spread of disease? Are there negative impacts to wearing them? I mean, some people are saying they cause diseases.
Yeah. So the cause disease is misinformation. Here's the thing. This virus has a lot of allies. Never would I have thought that we would have a pathogen that had allies, and the allies are the misinformation people who go on online and there's no the virus is not being transmitted because of masks. This is the question I ask people. If I have COVID and your grandma is standing in front of me, do you want me to sneeze with a mask on or without one on? Do you want her to have one or without? So if the answer to that question is no, then we can't really advance this conversation past right now. So if you say, I don't want a mask, and you're sick and my grandma is going to get coughed on. So once we make that assumption that we know that a physical barrier probably decreases transmission, is it always 100% effective? Well, probably not. Nothing is. But when you're talking about a hospital system that I run the infection control, where we have at one point in time, we were having hundreds of healthcare workers exposed every day. Okay. Patients come in, we don't know they have COVID. Healthcare worker has a mask on, they didn't get sick. Okay. So I watched this happen every day because remember, our testing remember way back a year ago, it took us a couple days to get test results back. Now we all test in-house. But we had exposures every day. And when the healthcare worker had on eye protection mask, they didn't get sick. They didn't test positive. There was a great article, and I'll try to email it to you, that had a list of 49 articles, scientific papers showing efficacy of masks. We published the case at Great Clips, if you remember back a year, where the hairdresser was sick and none of the clients got sick. So we know this. We've done this over and over. And there's so much confirmation bias where people want to grab onto one anecdote or one non-controlled paper. But I always just rewind it back to the fact, if I'm going to cough on your grandma and I have COVID, do you want us both to wear a mask? And if the answer is yes, then let's just start building on that faith. And there are no adverse consequences of wearing a mask. I've had one I work 12 to 13 hours a day, every day. I mean, 4 months without a day off almost, and had a mask on the entire time, and no adverse consequences. I just can't think of what it would be short of this misinformation.
Well, and then as a follow-up, many people live with children who are too young to get vaccinated, or those who are immunocompromised. So I think what they're wanting to know, especially our faculty who are, face-to-face with students so often, if they're vaccinated and wearing a mask, how confident should they feel that they're not going to take that home to their kids or to their immunocompromised loved ones or something like that?
So if you're vaccinated and you have good mask compliance, meaning everyone in your campus is wearing a mask face-to-face, the probability of getting infected is pretty low. And we know this within our healthcare system with 12,000 employees. We're watching these things happen. People test positive. Here's where they do get sick, and here's where we do have healthcare workers test positive who are vaccinated. They don't get severely ill, but theoretically, yes, they could go home and transmit it to their vaccinated loved one who's immunocompromised and responds less well to the vaccine, right? So if somebody's getting chemotherapy and they were vaccinated, they may not respond as well. And then that worker who got exposed can transmit to them, and maybe they have the sniffles for a day. So that chain is going to happen, and the mask might be ineffective. But here's what we learned. Over 18 months, the majority of our transmissions in our healthcare system were behind the scenes. They weren't patient to patient. They were either at home or they were in the break rooms where people took their guard down. So we had outbreaks within certain units in the hospital or certain clinics that were all linked when we traced them back to the break rooms. People take their masks down. We've learned since then, and they sit and have lunch and chat like we have to do as humans. And that's where we saw the outbreaks. So yet when they worked face-to-face with patients with COVID, everybody wore a mask, they didn't get sick. So I think that it's one of those things where it works if you keep your guard up all the time. But if you have that distancing, if you can find ways where you can eat and drink and be separated in space or time, it can be done. Those areas you can take the mask down. But boy, if you're trying to keep operations going and you want to go through school and you've paid tuition and you want to make sure you're in person for your education, which is your soon-to-be livelihood, it's your talent, it's your new identity, you want to be in class and you don't want to be quarantined. So get vaccinated and wear a mask, and then you won't be quarantined for exposures or isolated for infection. I mean, this is your one shot. I look at it with my kids. I'm like, this is important, high school first days. So I want them bomb-proof.
Yeah, bomb-proof is a good way to put it. Bomb-proof from anxiety of starting high school would be good for parents too, right? Let me talk to you a little bit about testing. A couple of things. A lot of people said, flu nearly disappeared. We were all wearing masks. We were social distancing. Some people, I think, thought maybe COVID cases were misdiagnosed and they were really the flu. Are there two separate tests? I mean, do you test people's nose swab for COVID and influenza? I mean, how do you know those weren't influenza?
So that misinformation, I'm glad you asked that. We have tests that detect multiple respiratory pathogens. The main test that we use tests for influenza, COVID, and flu A, flu B, and COVID. And we didn't see flu A or B this year. I mean, incredible. Where Greene County was having 3 or 4 cases, and we were still running influenza tests because remember early on, we were looking diligently for co-infections because we didn't know a lot about the virus. And we tested with high scrutiny for influenza, looking for flu, and just didn't see it across the US. The way that PCR testing works, it cannot be a false positive COVID because of influenza. They're not the same family of viruses. The testing technology is not the same. We used specific influenza tests. We even have the cartridges, our main test that a lot of hospitals use that detects the genetic material of flu A, B, and COVID. And rarely would we have somebody co-infected. We had a couple of those early on. But no, flu went away because of all of the mitigation. And we saw a good uptake in the flu vaccine this last year.
What can you educate us about the PCR and antigen tests and their accuracy level and kind of maybe what those differences are?
Yeah, so the PCR detects the RNA of the virus. It's very sensitive. It looks for dead or live virus genetic material, not live virus. So if I get COVID and you do a PCR test on me, that will detect the RNA pretty early. So just the genetic material of the virus. Mm-hmm. And even when I'm better, it will detect it for several days afterwards, maybe months. We learned all this last year. We had people who were infected and they had a positive test 90 days later. So that's the PCR, because what happens is your white blood cells eat the virus. They still live in your lymphoid tissue, your lymph nodes, and those white blood cells have that RNA in them because they killed the virus. And so a lot of times you're detecting dead RNA. The antigen test looks for the antigen, the protein on the outside of the virus. So you need actual virus. And so it has a shorter window of positivity. So it may take another day to become positive, and then it's become negative quicker. So somebody could theoretically, on the tail end of their disease, have a negative antigen test or at the very front. But when the antigen test isn't as good as the PCR as far as sensitivity, meaning it might miss some people. But when there's a lot of cases out here, a positive result in an antigen is a positive test. But when the cases start to go away, that test can have false positives. But like, for instance, if there was no COVID, then a positive result might actually be a false positive. But when it's high, those are all, and we confirmed these for months and months. We did antigen tests, confirmed them with PCR. So your window for antigen's a little less good. It's a little less sensitive, and PCR can stay positive for months or weeks.
Gotcha. Thank you. One questioner wanted to know, are hydroxychloroquine and ivermectin effective treatments for COVID?
Yeah, I mean, I wish. So here's the people who say, that I'm on the nickel for pharma. Let me put that to bed. That I'm getting paid by big pharma. That's the incentive, right? Remember, the government bought those vaccines. We don't pay for those vaccines. Nobody gets any money. They're not FDA approved, so they're not marketed. So there's no drug rep out there selling these vaccines, and no doctor anywhere in the U.S. gets paid any money for anybody getting a vaccine. Now, there's fees that hospitals can charge insurance for administering the vaccine, but no doctor gets money for the volume of vaccine that's used. The same goes with hydroxychloroquine. Our healthcare system, when we first had discussions that it worked, we bought a bunch of hydroxychloroquine for a lot of money. We hoped that it was going to work. Not only did the clinical trials where you do randomized placebo-controlled trials, so you give half the people hydroxychloroquine, half get placebo, and they end up in the hospital the same amount. You can only do those studies for so long, and when the data are so compelling, you have to stop. You have to move on. So we've moved on from hydroxychloroquine. I've taken care of hundreds of patients who took hydroxychloroquine and ended up in the ICU. I've seen thousands of patients with COVID. It's all I do, all day. And we have patients on ivermectin right now. That's the big craze. And there were originally studies that had signals that it reduced the amount of RNA in your nose. But when you test ivermectin versus placebo in large multinational randomized placebo-controlled trials, it doesn't help. So at a certain point in time, you can't continue to give something that in randomized placebo, just because a doctor says he gave 100 patients last year ivermectin and they got better. Well, we had 300 patients that got vitamin C and they got better. Because remember, most patients didn't end up in the hospital before the Delta variant. So of course the doctor says, I gave it to 100 people and nobody ended up in the hospital. That was the normal course of the disease, untreated. Now with Delta, we have an ICU and there are dozens of people who've taken ivermectin in the hospital. We have not seen it bend the curve. And when you apply the rigor of science, we're all trying to look at things through an objective lens. I hope it worked. I mean, I hoped and hoped it would work. I don't want to do this anymore. I don't want to see people sick in the hospital. And we hope that it would work. But really, I can't ignore these compelling randomized placebo-controlled trials. And that's all. And people can take that or leave it. I know people are dug in out there. I wish it worked, but they could come in our hospital right now, dozens of people who've taken ivermectin and they unfortunately still get sick. What we do know, and this is a PSA on my behalf now, the monoclonal antibodies do work. So if somebody gets infected, you really need to call your doctor and look at the monoclonal antibody, the Regeneron, the REGEN-CoV infusions. Those really do help, both in the evidence, in the literature, and in our experience. So I would not waste people's time on ivermectin. I would probably go, and again, those are emergency use authorization. They're distributed in a different way. Hospitals aren't making money on these. We're not buying Regeneron and making money. It's the government has subsidized this. So those drugs do work. And I really, really want people to seek those out if they get sick and get infected.
Dr. Trotman, I'm going to have one more question for you, a few more for Dr. Higdon, and then wrap it up. One thing a lot of people wanted to talk about, or have you talk about, is how do they talk to their friends, their students, their family members, their colleagues who are reluctant to get vaccinated? What would you tell us, maybe what you see every day, and how many people who you're treating who aren't vaccinated versus those who are vaccinated, their level of disease? Talk to us a little bit about that.
I mean, it's an existential crisis right now. The healthcare systems are stressed. This is a pandemic of the willfully unvaccinated. So this is a self-inflicted problem right now. As Dr. Higdon said, we have choices right now and we have the opportunity to do something. So I tell people, if you're reluctant to take the vaccine, I admit, this is not a risk-free decision. Both have risks. There's side effects, risks. But do you want the known risk that we know is very small or the unknown risk? Now, again, a year ago, I would have said, if you're healthy, save the vaccine for the old people, for the immunocompromised. Just take care of yourself. You won't end up in the ICU. Shadow me for a day. 20 to 30, 40-year-old people, contemporaries of mine, seemingly healthy, in the ICU, critically ill. We didn't think this would happen. I used to be able to predict who was going to get critically ill. I used to be able to say, well, 92-year-old patient on steroids, she's not going to do well, but he's going to do fine. Anymore, we can't predict that. We're out of ICU doctors, we're out of nurses, we are struggling as a healthcare system to take care of this preventable disease. Do we see people in the hospital that are vaccinated? Rare. We do. I mean, I can't lie. The vaccine was never reported to be 100% effective in preventing symptomatic disease, but they are rare. And almost all of them, you could have predicted who's going to get vaccinated yet get sick because their immune system was already weak. They wouldn't have responded to any vaccine. So I tell people, picture an ICU with 70 patients, the median age, meaning half are above and half are below, being 50 years old. That's very different than a year ago. A year ago, we had nursing home outbreaks with 90-year-olds, and it was awful. This is worse because this is people our age, the healthcare workers, the nurses, RTs, they're taking care of patients that they're looking at in the mirror. It's that compelling. So I tell people it's a pandemic of the willfully unvaccinated. You need to take care of your community. You need to think altruistically. And then think about it in terms of risk. You don't want to be in the ICU. You do not want to see me in one of our ICUs. It's not good. And unfortunately, this Delta variant is more severe. People get sick faster. We're pretty confident in this. And so it is about risk. It's the risk you know or the risk you don't know. And so that's how I try to help people wrap their mind around it. And then I will send you the link, or you can post that link to that echo that we did with Dr. Paul Offit. And he really does a better job than I can of quantifying those risks and giving you the speaking points to say, yes, that risk is there. Myocarditis in a young man can happen. Here's the numbers after COVID. Here's the numbers after vaccine. So I try to listen when you're talking to family members and loved ones and they're really reluctant to take the vaccine. I really try to listen. I try to hear their concerns, validate their concerns, a lot of uncertainty, understand where they get their information. That's important. And then, just trust your trusted health experts. The only vested interest I have in this is human health. That's it. There is no financial gain. I want this over. I want to get back and go to concerts and feel comfortable. So that's about all I have to offer.
Dr. Trotman, thank you so much. Hang on one second really quick. We got a couple of things just about classroom management with Dr. Higdon. Dr. Higdon, should instructors from seated classes allow students to voluntarily attend virtually?
That is a question really I would not want to interfere in the provost's role. That is Dr. McGrady's role. Dr. McGrady, the deans and the department chairs would be better to answer that. Obviously, we're in a very different position than we were last year, but I'm going to leave that to Dr. McGrady.
And then, we talk about flexibility, Dr. Higdon, on due dates, expectations on attendance. I mean, we're pretty much back to normal unless a student is impacted by COVID, right?
We are back to normal. We've been back in person for a year, unlike some of our sister institutions in other parts of the state. Southwest Missouri, we safely went back to school last year, and we were masked, and we're going to be masked again. So I would say it's all systems normal, but I always know that our faculty and staff have a heart for students, and I would say that, to be as flexible as you can, keeping in mind that they're here to learn, and they can't learn if they're not in class or attending virtually. And again, I would defer to Dr. McGrady and the deans on that.
Sure. And again, thing here on working in pairs or groups, avoid working in groups, but there are just some classes it cannot be avoided. So we just want everybody to do their best. The
only thing I would say is if you're vaccinated and masked, I'd feel a lot better about being in the classroom than I would be unvaccinated and masked. One of the two are good. Both of them, as Dr. Trotman said, bulletproof or bomb-proof. You want that, if you're believing superheroes, you want that shield around you like Captain America, and that's the vaccine.
Raise deflector shields. So, Dr. Trotman, you've been very generous with your time. We thank you. We appreciate the work and you and all the other healthcare workers do to keep our friends and loved ones healthy. And this has just been so educational. Do you have anything you'd like to add that we may not have addressed here today?
Yeah, I mean, I have a personal interest in the welfare of OTC because I have a clinic, I have a practice, I run infection control in our hospital. Your students and some of your faculty are in our building. I want them to be well. That's it. That's the only driver, the North Star of all of this, all of our time, unrelenting effort in our healthcare system is human health. So I do care about those people because I have people I work intimately with that trained at OTC. So I do have a vested interest in it, and that's all it is. And I hope that people will come away with this. There is one more medical issue. People want to know if they've been infected, should they get an antibody test? This is, I'm sure, a question we'll get, and then not get vaccinated. But there was an MMWR that was just published, great infographic if you want to look at it. If you've been infected and you get vaccinated, your neutralizing antibodies are through the roof. You want to talk about superhero status, superhero powers. That would be the person who was previously infected and got 2 mRNA vaccines. That's a good situation to be in. That's one where I would feel comfortable being in a classroom with 100 people masked, and I wouldn't think twice about it. So the big question, if you've been infected, should you get vaccinated? You got to wait until you're no longer symptomatic. You're out of your isolation period. Sometimes I tell people maybe wait a month, make sure you're feeling better, and then get vaccinated anyway. And then you're in the best situation.
Well, I said I wouldn't ask any more questions, but you just raised one. If you have had COVID, that doesn't mean you're bulletproof and you don't need to get vaccinated, right?
No, we have reinfections. It's a hard number to quantify how many people have been previously infected that get sick. you do have pretty good durable immunity, but it's probably not as robust. It does last a long time, but it probably doesn't fire up as good. So I recommend people, you get COVID, get over it, wait a month or so, make sure you feel better, and get your 2-shot mRNA vaccines. People ask about the Johnson & Johnson vaccine. There is a group of people that we don't give it to. We don't give it to kind of women of childbearing age because there is a increased risk of blood clots. It's less than smoking. So the Johnson & Johnson blood clot risk is way exponentially less than smoking and some other issues that increase your clot risk. But it is out there, some platelet issues. So young and middle-aged women, I recommend they don't receive the Johnson & Johnson vaccine. They can, but it's, we're talking in the orders of 1 in several 100,000 risk, but it is there. So yeah, if you've had COVID, go ahead and get vaccinated, but wait till you feel better. And then, like you said, my parting shot is just trust those of us in the public speaking world, and maybe even just think about flipping your civil duty and responsibility to that of altruism. And maybe not for people who see kind of the polarization of our community and our society, that doesn't help. This is not a red or blue issue. This is a humanity issue. So think about it through that lens. Think about it through the traumatized nurses that have had 5 young people die in the last month. Think about your duty and responsibility. And then get through your classes there and stay safe and get out in the workforce. We need people right now. That's my PSA.
Dr. Trotman, thank you so much. Dr. Hagan, final thoughts.
Dr. Trotman did a better job than I did. I would just say if you're an employee of the college or a student of the college and you're watching this and you're not vaccinated, you should be convinced after this. Don't listen to misinformation. Listen to smart people. I've always found that if I listen to people smarter than me, I do better. And there's nobody I respect more in this town than Dr. Trotman and the organization he works with, and Mercy in our health department. They're here to help us. Please listen to them.
Hey, my rule is I listen to people who are smarter than me, and that's why I'm a good listener. So, so faculty, if you have any other questions of an academic or classroom management question, please talk to Dr. McGrady, email her. For other questions we may not have answered here today, you can send those to communications@otc.edu. But I appreciate everyone who submitted questions, and I try to get to them all here today. We plan to go half an hour. We went almost an hour because Dr. Trotman was so awesome. And again, we thank you so much. So thank you everyone for attending today. Dr. Trotman, thanks for being our special guest. And hey, have a good evening.